Thank you for a wonderful panel and for that last word, which was a critically important lesson for all of us. It was especially fun for me not only to listen to these extraordinary panelists, but because the first public meeting that I attended in North Carolina, if I can recall correctly, a few decades ago, was chaired by an incredibly skilled moderator named Dr. Tilson. And here again, we have an incredibly skilled moderator, Dr. Tilson, moderating this panel today. So again, as we welcome the new panel 4 that's coming up, let's thank our previous panel. The fourth panel of the symposium, Connecting Care, Moving Towards Seamless Information Flow and Data Sharing, is moderated by Dr. Aaron McKethan. Aaron is a senior policy fellow at the Duke Margolis Center for Health Policy, and he's also the CEO of Novisci Incorporated. He's joined on his panel by Patrick Getzen, Annette DuBarf, Eugenie Komives, Jessie Tenenbaum, and Matthew Ewend. Aaron, thank you very much.
Great. Thank you very much. Hi, everybody. This is the Data Nerd Fest panel. So that could be really off-putting to some of you. But I assure you, we're going to try to not be too nerdy today. In fact, when we had, and by the way, what exceptional preparation, Jessica and others, for getting us to this day. What a great day this has been. I don't know how long it's been since Secretary Cohen's been in the same room all day. But it's obviously a good sign that things are going really well here. So in our prep conversation, we discussed the fact that we don't want this to be the quote-unquote IT panel, the data IT panel. We're not going to talk about data standards, specifications, and the like all that much unless you force us to with your questions. We prefer you not. Please don't. Because we want to talk, the panelists here were selected, what a great group to my left, to really think about what are the information needs of this changing healthcare system that we have. And I appreciate the Secretary beginning this morning with reflection on health as the true north, and it's worth every day reflecting on that. Why are we doing all this anyway? And furthermore, to put that into terms that we can know if we're winning or losing. What health are we talking about? For whom? And which direction are we going in? Sadly, despite all the great hype of North Carolina, which is both exciting and somewhat nauseating, admittedly, because we have to earn that hype. We have a lot of work to do to earn that hype around the country. Despite that hype, in many dimensions, we're not doing that well as a country with respect to that true north of health. Our life expectancy is actually going backwards, and when I tell young, enterprising, college students at UNC and Duke that they're learning health policy, their eyes widen. They were led to believe that the greatest country and the richest country in the world ought to constantly be improving in its life expectancy and health outcomes, and in many ways, we're not. And a lot of the disparities that were discussed today are further evidence that we have a long way to go. And we also recognize here that that information, data and information, are not just nice to haves in this environment that we're trying to build toward this vision of a healthier North Carolina, but they're crucial. And we've used the word humility a lot today. I'm reminded of that quote that says North Carolina is the valley. Help me out. What is that quote? North Carolina is a vale of humility between two mountains of conceit, referring to our two northern and southern states. No one's ever heard that quote? All right, Google it and let me know if I'm getting it right by the end of the panel. Something like that. So anyway, just to prompt. So I've been in at the state level and the federal level, and in the private sector, working on various aspects of data analytics, and it can seem a little abstract. And what I want to do briefly before I introduce the panel is to tell you a brief personal story that I actually don't typically talk about, but I'll tell it to you because in the last few years, despite having been in the field of health data and technology and analytics for a long time, I realized, it became very personally real, that we have a long way to go to build the kind of information infrastructure that we need as a country. So 4 years ago today, actually 4 years ago this month, my father, who lives in Watauga County, died. He had lung cancer. He was diagnosed 13 months prior with, and I was sitting there with Mom and Dad at the primary care doctor getting the results. They decided to route the results to the person that they trusted and knew the most, and it was not a good day. It was Halloween, actually, the year prior when we got the diagnosis. And it was late-stage cancer, stage 4. It was lung cancer, very common form of lung cancer. And so there we set out figuring out what are we gonna do now. And at the time, we lived in Washington, D.C., so I grew up in North Carolina, moved to D.C. for 9 years. As soon as we got that diagnosis, my wife and I looked at each other and said, time to go home. We gotta go be with Dad for as long as we can. He won't be here very long. Let's do it. So we rented a house, sight unseen, in Chapel Hill, so we could be close to an airport and keep working, but otherwise we're spending a lot of time in D.C., or in Watauga County. So the reason I'm telling that story in the context of data, as we got into the treatment process, I wanted to know how many, so Dad got on a treadmill for chemo. It was time to get chemo. There wasn't a lot of question about it. Just kind of, now your chemo appointment's coming up. And I wanted to know how many people like Dad get that chemo. And it wasn't because I was second-guessing the doctors who we thought were fantastic. It wasn't because I wanted some sophisticated algorithm to tell me which chemo drug he should use. What we wanted to know is it possible for Dad to be able to go down to the beach to be with his brother, who at the time was also suffering from cancer, getting treated every day with radiation? We were trying to find an opportunity for them to sit together for a few months, just laugh and remember and tell stories. And so chemo was obviously very logistically complicated. So we were just trying to figure out, is it 2% of patients like Dad that get this chemo and therefore kind of need to be back at home and dealing with that? Or is it 80%? You know, that was kind of the basis of our question. And it was so shocking to me that no one could tell us the answer to that. No one knew. And these are great doctors. We'd send others to these doctors. So the lesson for me in that was, despite what you typically hear at conferences where there's a panel on data and analytics, which is about deep learning, like nod your head if you hear all this, deep learning and machine learning and all these things, that's great. But guess what? We have a health system that can't even count. We can't count things very well. We can't count them systematically. So I like all those things. Hats off to Karen DeSalvo, who's going to fix a lot of the nation's issues with data at Google. They'll use all kinds of sophisticated algorithms, but we first need a system that can say how many people, 65-year-old white former smoker with this very common cancer, who's a Medicare patient, get this treatment, and how many of them that get this treatment are still alive 3 months later. Those are the very practical things that we have to get to. So I think part of the challenge of building a healthcare information architecture is that we're doing it in the abstract. We need to do it to solve very specific problems like that. Answer very specific questions and solve really specific problems. That's a long way of saying Dad did get to go to the beach. He did get the chemo, but he did go to the beach, and that was an important quality of life dimension that we cherish to this day. I was just looking over there at a picture of Dad and Uncle Gene on the beach enjoying their last months together. So data matters, and every numerator and every denominator is a person. And so this panel is going to be trying to bring that to life and ask the question, how are we doing in North Carolina to fulfill the vision of a payment system that rewards quality and outcomes and health, that has organizations capable of taking downside risk? How can they do any of that unless they have information about who their patients are, where they are in the system, and how to help them? So let me now introduce the folks on the panel. I'm going to start just to my left with Patrick Getzen. And by the way, I was also reflecting on this list I'm going to read for you. These titles only reflect their current roles, but many of you know these folks to my left have been very impressively involved in all sorts of things in different organizations in North Carolina and around the country. Patrick Getzen is the Senior Vice President and Chief Data and Analytics Officer at Blue Cross and Blue Shield of North Carolina. We'll start out with him in just a moment. Dr. Annette DuBarf is currently a Vice President of Clinical Strategy at Alidade, based in Bethesda, Maryland. She's based here, but they're based there. Is that right? Okay. Jessie Komives is Dr. Jessie Komives is the Chief Medical Officer of WellCare of North Carolina. That's a role that you've had for how long? 4 months. So she'll tell us about some other roles and hats she's wearing to talk about data that go well beyond the 4-month stint at WellCare. Dr. Jessie Tenenbaum is the Chief Data Officer, fellow faculty member at Duke, but Chief Data Officer at the North Carolina Department of Health and Human Services. And she's, by the way, much better in that role than her predecessor. And finally, Matt Ewend. Dr. Matt Ewend is the Chief Clinical Officer at UNC Healthcare and President of the UNC Physicians. He's also a neurosurgeon. My first question for you in a minute will be, how many years have you been in school to be a neurosurgeon? But I'll come to that in a second. So count it up while you're waiting. So Patrick, you are responsible for data and analytics at the largest insurance company in the state. When we talk about interoperability, maybe we start with just what problems are we trying to solve when we talk about that, and what tools do we need in North Carolina to do so?
Okay. Thank you, Aaron. Let me start by saying the really sad thing about your story about your father is that the data probably did exist. It's what I kind of like to say is that we are very data rich in healthcare. It's not integrated very effectively, so we're pretty insight poor, and then we're absolutely execution poor, even with the insights that we have. So it exists, it's just not housed correctly and used correctly. So there's a lot there. So Aaron said we all had different roles in the past. I am the Chief Data and Analytics Officer at Blue Cross North Carolina, but for a period of time, I used to be an actuary. And I spent a lot of time thinking about the business problems we needed to solve in healthcare. The 3 outcomes that we all like to talk about are affordability, quality of care, consumer experience. As an actuary, I spent most of my time on the affordability side. And there were a couple of kind of data points that used to really bother me. The first is that healthcare premiums go up 6 to 8% per year on average. Salaries go up 2 to 2.5% per year. And you don't need a designation as an actuary to understand that over time, that's an unsustainable cost model. So the other thing is we recently have done some affordability analysis to look at what percentage of household incomes in North Carolina are going towards premium and out-of-pocket costs. And I would say that it's startling to find how much people are paying for health care. But what's even more startling is how it degrades over time because of the first data point that I gave you. So we really are at a point where we need to do something and do something fast around that. So to the point Aaron's talking about, we have these tools that are available to us. We need to put them to use. One big step Blue Cross North Carolina is trying to tackle on now, which you've heard about, both in sessions today but also in media releases for Blue Cross, is moving towards alternative payment models towards value-based reimbursement. And that's a program we launched this year called Blue Premier. We've done it with, we launched initially with 5 systems. We've added 2 more recently. But the idea is that we want to move from paying for volume of services to paying for value of services. I'm looking in the audience, and I see many people who aren't young enough to have been around in the 90s when we tried to push risk onto the providers back then. But for those of you who weren't around, I'll just kind of give you the cliff notes. It didn't work. And part of the reason for that was we said, hey, great, docs, we're going to put you on risk. We never gave them any tools. We never gave them any data. We never gave them any insight. And as a result, it was a pretty big failure. So people ask me, what's different about today? And I say there's 2 things that are really different. There's one thing that is different that people don't talk about, and then there's one thing I worry about. So I'll go through those with you really quick. The first thing is data is very different than when I started in this industry in the 90s. And it's not just the clinical data or the claims data. You've talked about social determinants of health. We're not a fan of that phrase either. We call it drivers of health. It tells you not only what a person's health risk status is, but why it's there. So we go from correlation to causality. The data sources are much more larger in volume. The second thing is, although Aaron did mention it, tools are better. I used multiple regressions when I first started off. Now we have predictive modeling that's much better than it was before. The one that we're going to talk about a little bit more today that people don't like to talk about is how do you actually exchange that information and that insight or interoperability. This is a really important piece because if you think of the steps to value, which are data, finding patterns in the data to give you insight, you still got to do something with those insights to actually create the value. In exchange, this tool is a really important part of this. So, and then the final thing that worries me a little bit is you have to get it into workflow. So when I think about Blue Premier and what we're doing with providers, I really think that it's not enough. All the steps are important. Data is really important. Insights are important. Giving insights is important. Somebody has to accept those insights and then do something different with that insight to create a better outcome.
Let's begin the tradition of clapping for our fantastic panelists, because that was great. So, Dr. DuBarf, you have spent a lot of your career working in the primary care world and understanding the needs and information and otherwise of primary care practices. Reflecting on what you've just heard, how do you reflect on now the state of primary care in North Carolina with respect to information? What do they need? How well equipped are they to get it?
Great, and thank you for letting me be a part of this panel. To give some background of the perspective I'm hoping to bring, Alidade, the company I'm working with right now, is very particularly focused on helping independent primary care practices succeed and thrive in value-based care models. And so we work in 25 states with 6,500 independent primary care physicians, helping them organize into accountable care organizations and get into value-based contracting with Medicare and commercial and Medicaid payers. And importantly, bringing not only that opportunity and the size that it takes to do that well while maintaining your independence and serving your community, but giving them the practical help and very often that means the data and the technology it takes to kind of step up and recognize the needs of your population and tend to those needs. And it's going well. Our partner practices across, I think we had 18 ACOs operating in 2018, generated $69 million in savings to Medicare in 2018, and are having substantial success in commercial value-based contracts in other states. But I would tell you, we've been in North Carolina a little less than a year now, and this has been our fastest growing state. We already have 1,600 primary care practices across 180 practice sites that are working, that are grabbing the opportunity to work with Blue Cross on Blue Premier and to do Medicare and hopefully coming soon some additional commercial value-based contracts, because primary care practices are very ready to be valued differently and to be recognized for the actual value that they bring to the healthcare ecosystem. So the business model of Alidade is completely predicated on the notion that doing primary care the way it was meant to be, meaning you have access to a primary care provider who knows you and will see you when you need to be seen and will have a longitudinal relationship with you and cares about your total health care needs and will coordinate those needs. That is actually the key to success after all, and that is the model that keeps people out of the hospital, keeps people out of the emergency room, reduces unnecessary duplicative testing, unnecessary specialist visits. And so I think back to your question, the information, primary care practices are working in an information vacuum. And the reality, this has been such an exciting day because we're talking about such meaty, great stuff. But there is a stark kind of reality check that I just want to provide on what is the usual care in our communities across North Carolina and really all the states that we're working in, which is that if you have managed to keep your business alive as a small business owner trying to provide primary care in your small community, and if you've stayed alive this long under the U.S. healthcare system fee-for-service model, you are seeing 30 to 40 patients a day. You are cranking through, you're making decisions at the second. What problem am I actually going to try to address versus what do I just have to put off to another day? You are quick to refer if anything comes up that you can delegate to a specialist. And you're churning through. And that way you are able to pay your staff, and you're able to keep your doors open, and you're able to keep an access point to your community. So it is very different what we are trying to allow primary care to get back to, which is give patients, build the relationships that your patients need, take the time that they need, take the time to really assess healthcare risks and social needs and wishes at the end of life care. Take that time, wrap your arms around your patients, and reach out and make sure that you know when they're in the hospital or in the emergency room, and you're bringing them back in, and you're making sure everything is smooth during those times of care transition. So the information needs for that are not that fancy, right? I need to know what is going on with my patients. I need to know when they're in the hospital. I need to know when they get out. I need to know where they're going. I need to know when they're coming out of the skilled nursing facility. If I'm going to take total cost of care accountability, I need to know more than what I bill, because that's only 3% of the whole picture. I need to know where the other 97% is going. And I need to be eyes wide open about where the healthcare dollar is actually spent, because most providers out there don't have a clue. So it is getting that information into the hands of providers. Is this really the best use of the healthcare dollar for this patient? That they are seeing 3 different cardiologists, and they're getting their blood pressure checked by 2 different nurse practitioners in 2 offices every other week, and that they had a 3rd abdominal CT scan because they ended up in 3 different emergency rooms over the past 3 months. So there is very basic informational needs to really help illuminate where the healthcare dollar is going and where the patient's needs are. And we do fancy stuff too. We do some machine learning, and we, predict who's most likely to come to go to the emergency room within the next 3 months, and we predict risk of mortality so we can flag patients who haven't had advanced care planning, and are laying in those kinds of really actionable need-to-know information to make sure right patients are getting right care. But the information needs really at the core are much more basic than that.
So we've heard this morning or in this afternoon about the Deming quote about systems design and what they get what they're supposed to and the like. So Jeannie, I was reflecting on that. Universities are designed. The production function of universities is to produce papers and grants. And so when you say to them, do something for the world, that's really hard. They want to, but they have this overriding desire to produce more papers and grants. A big health system's historical design is to do more tests and procedures, and a health plans is to pay claims and try to not pay as many as possible. Come up with a way to not pay them. So those are some pretty embedded. Those are pretty embedded systems to overcome. And you've sat on both sides of a health system and now health plan, and previously with a health plan. What does it take against that North Star of health? How do we re-engineer these big bureaucracies so they produce something different?
Whoa. How about an easy question to start with? So as Aaron alluded to, I trained here at Duke, family medicine by training. Spent 11 years at Kaiser Permanente. Believe it or not, there was a Kaiser Permanente in North Carolina. Those of you that are young probably don't ever know that because it went away before you were born. And then I moved over to Blue Cross Blue Shield, had the pleasure of working with Patrick for a number of years over there on kind of all things quality, provider quality. We actually started doing some innovative provider agreements back then, but we didn't have nearly the sophistication that I think the team there now has really brought to that. And I got enticed back away to return to clinical practice at Duke, and about a year and a half later joined the Accountable Care Organization at Duke as senior medical director there. And 4 months ago, I can blame Greg Griggs in the audience for that, but I joined WellCare North Carolina, which is one of our new Medicaid prepaid health plans, still waiting to launch. But, so we'll move past that, yeah. But so, Aaron, I think, really wanted me to try to speak from the healthcare system, the large health system perspective. Man, it's complicated. I mean, and so you're right. There's conflicting priorities when you deal with large health systems. In a way, I'm jealous of Annette because when you're working with primary care practices, in a sense, they're sort of pure, right? They have to keep the doors open. They got to see their patients, and they're probably more agile to make decisions and make changes than in a big system. But what we were trying to do at Duke was take a limited resource, care management and IT, data informatics, and figure out how best to deploy those limited resources so that we could manage within the Medicare Shared Savings Program. We were in an upside-only arrangement for 3 years, and then a track 3, which is up and downside risk, for the last 2 years that I was there. So number one, care management. So you got to figure out who are you going to manage, right? Who are the patients that you're going to deploy that limited resource for? And when we had our call, and Annette told me we needed to make this spicy, so I'm going to make it spicy. But we talked a little bit about the issue of sharing cost data back and forth between plans and providers. And I think it was said earlier, it's easy in Medicare and Medicaid because they're all the same. Well, they kind of are the same. Certainly in Medicare, there's a standard payment scheme. But for Medicaid right now in North Carolina, it's, we're negotiating individual contracts. So I think that is a little bit more controversial. But in Medicare, we had cost data at Duke. We actually didn't use it. We built a deep machine learning predictive analytic model to figure out who was going to end up in the hospital in the next 6 months. And that was really just kind of a guess and talking about unplanned hospitalizations, which we were able to identify. And we used a combination of our clinical electronic health record data as well as the claim data that we got courtesy of Medicare for being an MSSP program. And we had pretty good predictive capabilities in that model, which is great. And so we deployed our care managers and said, dig in deep, really work closely with these highest risk patients, and let's see if we can't avert some hospital stays. I wish I could tell you that that was wildly successful. It wasn't the predictive model that was the problem. I think it is really hard to change the trajectory of health for the sickest of the sick in the Medicare program. And so, more work probably to be done on that. But it was a great example of how you can take data. And I'll say claim data alone, we got reasonable results, but the EHR data on top of it really enhanced the model. So the power of the health system having access to both types of information. Now, I got asked at WellCare, are we going to share cost data with our providers? And we've had providers that have asked us if we would give it to them. And this is a little controversial, but I've said kind of like why. So the model that we built at Duke didn't even look at costs. We were looking at events and diagnoses and pharmaceuticals and other information that we had available. And it predicted, quite frankly, just fine an event that an unplanned hospitalization really should be a never event, right? I mean, in the ideal world, nobody would go to the hospital for an admission that they weren't planning on, like an elective knee replacement. Now, we understand you're never going to get rid of 100% of unplanned admissions, but they're not an event that anybody wants. And we were quite capable of predicting those. It was more bending the outcome of that was the challenge. Interestingly, there's been now some controversy. So there is a predictive model, I think it's called Impact Pro, that a large national payer uses. And I think this is maybe Massachusetts, but there's a big lawsuit, or New York, big lawsuit. And the problem is that model actually uses cost, predicts cost. And somebody published a paper, much smarter than me, that analyzed the output of that model. And it turns out, because we're talking about equity today, that model over-predicts risk in white privileged individuals and under-predicts it in the underprivileged communities. And at least the theory is because for the same degree of illness, we people that have resources consume more healthcare, so we are more expensive, okay? But what it's doing is it's parsing those needed care management resources inequitably across the population. And so now I've been able to say I'm vindicated, right? So I'm a big advocate of using clinical data for risk prediction, but I'm not sure whether we need cost because of that. And interestingly, we looked at our model at Duke where we were only using clinical data. If anything, it overpredicted risk in underserved. So just interesting. And that kind of makes sense too, because if you have same disease state, but you have fewer resources at your fingertips, are you more or less likely to end up in the hospital? I think we all know the answer to that. So anyway, and then the other, I would probably be remiss if I didn't just mention quality data. And we've come a long way from running around the state collecting 15,000 charts for HEDIS. We're still collecting a whole bunch of charts for HEDIS, but the ability to exchange flat file quality data, and having been on the provider side of that, we wanted the claim data to fill in the gaps of what we didn't already know from our clinical record, right? So when we said in the Medicaid stand-up that the plan should share quality data with the providers, I'm more than happy to share it, but the truth is that the providers probably know more about their quality than I do, and they know it sooner because they're the ones, for the most part, that have rendered those services. So we're going to be doing it just to kind of help fill in the gaps, but I think we're coming a long way on the ability to mine quality data, registries, do quality gap closure, that kind of thing. So that's all good. Now, if we didn't have 67 quality measures. Right. Okay.
Great. Thank you. So as I shift to Jessie, I just want to reflect on a conversation I had yesterday by the water cooler with an entrepreneur who's in real estate. He's got a company in Durham that's working on predicting looking for leads, people who are likely to in the future want to buy a house, and therefore referring them to realtors. And we were sharing what do we do, and we're thinking about how do you get at the infant mortality rate when you think about the moms and the health status. You think about prenatal care. I was describing kind of the problem, right? We need to get more prenatal care earlier, but one of the challenges is how do we find out that you're pregnant if you don't show up into the health system until fairly late in the pregnancy, blah, blah, blah. He interrupted me and said, well, we just buy pregnancy data from purchase, that's available. And I think, okay, notwithstanding the kind of weird factor of that, that information as a father of four, what else do you have on us out there in cyberspace? But I do think we ought to be creative. Claims is important, but how do we put all the data sources that we have to use for the health outcomes that we're working on? And Jessie, you are now Chief Data Officer of an enterprise that has lots of data, lots of different types of data, probably so many that you haven't even gotten to them all yet. Data on everything you can think about in Medicaid, but also all the social services, SNAP, WIC, TANF, et cetera. How do you prioritize what data to work on and how to use it for good?
I was not anticipating that question.
Answer whatever question you like.
All right. So there is a lot of data at DHHS. So I've been at DHHS. Is this on? Can people hear me? No. Thank you. So I've been at DHHS for 6 months now, and I described my first few months as kind of getting the layout of the forest. And I felt like, okay, I'm finally starting to see the forest from the trees. But each time I think I get the rough shape of it, I realize there's a whole grove over there that I didn't know about. And then it turns out that grove is on fire, and we have to figure something out. No pun intended for the fire. So, thank you. So one way is just the size and the amount of money spent. That's one way to prioritize. And so certainly Medicaid by budget, and Medicaid and public health by just quantity of data are extremely important. But the integration, as you all know, right before I started at DHHS, there was a publication in New England Journal by Aaron and Secretary Cohen on the importance of integrating across different sources. And that's really the challenge. So when I joined, or I guess before I joined, they created the data office within DHHS. And earlier today, I talked to someone, and I mentioned who I was or what I did, and they said, oh, you're the IT person. And I bristled a little and said, not the IT person. And I realized it's subtle to other people, but let me clarify that you can think of it as plumbing. And the IT people are the ones who build the pipes and build the systems that are going to carry the content. And we informatics data science types are the ones that deal with the things that flow through the pipes and how we're going to make use of it. So that is our focus. The clean water. Well, funny you mention.
Incoming, the clean stuff.
The clean incoming stuff. I wanted to also clarify, you mentioned data quality, or quality data. We use the sense quality in two different ways, I think, in our different worlds. There's the quality measures, the HEDIS. In my world, we talk about data quality of fit for use. We know that we have a lot of data. Data by nature is messy and dirty and noisy. And what conclusions can you draw, what can you not? And so that's a huge priority of ours, to just understand the data assets. As you mentioned, Erin, there's a huge number of them. So figuring out what data assets do we have. Some people have alluded to data sharing and the difficulties of that. I come from an academic background, so I was at Duke before this, and there's this sort of theory of like, your data is my data and my data is my data. And we're getting better. There's a little bit more of a culture of data sharing, but now the problem is the metadata, understanding what that data is. Like, sure, I'll throw my data, here it is, but I don't know what a XQV5 variable means. You need sort of the annotation of that and to understand how it was generated, who it was generated by, to understand what you can use it for. The other thing, the background I have in biomedical informatics, we talk about the central dogma of informatics being from data to information to knowledge to action. So we talked earlier about, someone mentioned earlier that we are data rich but insight poor group, or just as a society. And so we're trying to take all of the data assets that we have at DHHS and use those to draw conclusions, and actionable ones in particular. For our data strategy that we've worked out, we're looking at just the infrastructure, kind of the IT parts to enable this, the governance, the policies, and how we do data sharing, the data quality to understand what conclusions we can draw, and then the usage. How are we using this? To the point about the machine learning and the sexiness of that, I love going back to Duke and giving a talk in which I show the deep learning network and say, this is what people in academia are concerned about, and it's the sexy buzzwords. And then I show the slide that has a SQL statement that's select with summarize, and saying this is really what the world needs, basically counting. I love especially doing it right after the guy who's really into deep learning.
Is that Ricardo?
No, but close. So I think I semi-answered your question, and then some.
Excellent, thank you. So Matt, yeah. Thanks. Okay, Matt, so how many years does it take to become a neurosurgeon?
That's my whole question.
No, that's part one.
Part one, yeah. I tell my kids it's 27th grade by the time you're done.
Excellent. So 27th grade. Okay, you're not selling it, but we do appreciate all those 27 years. Thank you. So I'm impressed for many reasons having you on the panel. You're leading a lot of value initiatives, all the value initiatives at UNC, and I wonder, just reflecting on what you've heard down the panel and what your experiences are so far at UNC in this transition, what perspectives can you bring from an information standpoint about where we are today and where we need to be?
Thank you. So I watched the Super Bowl 2 years ago. I don't remember who won. I don't remember who played. I don't remember what Fritos or Pepsi did to be clever, but there was one commercial that really caught my attention, and it was a Google commercial, and the tagline was something like, "Do you know what your data knows?" And that day I was thinking more like a neurosurgeon, and I'd had a patient who'd been postponing their surgery because they're on aspirin, showed up for surgery that day. That's a bad combination with a brain tumor. And I thought, we should know this. Like, somebody knew that patient was on aspirin. It probably should have been me, I'll admit, but somehow I should have known that. And now, as I sit working with our whole team on value, we really have to know what our data knows, and we don't. And beyond that, I don't just need to know what the UNC data knows about our patients. I really need to know what all of you know about my patient. And Patrick says that things will be better than they were in the 90s because the data is better and the systems are better, and I believe that too. But we have to execute on that, or we will recreate the 90s, and that's really my fear in all this. So we're okay. We know problems, and we probably can put together a decent medication list for most patients and allergies. But if you start to say to us, do you know what happens with procedures or with laboratories, we start to fall apart pretty quickly. And then if we get to pharmacy data or many of the things that we've talked about today that are really important for health but don't show up in Epic, we really have trouble. So getting our hands around that data and being able to use it, and as Annette said really well, we have to drive that down to the level of whoever the provider, and I use that term very generally, as who's working for that patient. And so it's not just enough that all the data is sitting on my system or that we look at it and gain some insights. We've got to make it actionable in real time to our people. And that is going to be a formidable challenge. And I think the efforts of this great state are going to hinge on that a lot. And so I'm hopeful that, that our data scientists will manage both sides of the pipes and make that happen. Yeah, we'll forget it really soon, I promise. So that's all. Thanks.
Thank you very much. So I'm gonna ask a couple of questions for anyone to take if you like. I have an extreme bias, as you can tell, for simple counting and solving problems that are right in front of you. So the first question is related to that. And to set it up, I'll just say, I was a federal official at the Office of National Coordinator Health IT in D.C. A decade ago now, and I remember giving the first grants to North Carolina to set up a health information exchange. And years go by, and I eventually kind of lose track of it, and I come home thinking, where's the information exchange? And there's still discussions about, is there an information exchange? And the thing that I learned, and now there is, thank you, Christy, in the back. We'll talk more about that in a minute. But it required state legislation to really get participation, which is my next point, really. There's often the folks who deal with data get yelled at because we don't have the data we need, blah, blah, blah. But it's often not a technical problem, but a business problem. As Dr. Cole so nicely said in the last panel about whether she asked the question, do we really want to do something about disparities? I think we have to ask the same question about data, because there's a lot of ways to share data. Sometimes it's Excel spreadsheets, and sometimes it's sophisticated data feeds. But the first question is, do we want to do it? Are we really committed as a state to actually sharing with partners and to expose what we don't have, or what we've typically held closely in the spirit of sharing and coordination? And I wonder, maybe I'll open it to anyone, but Annette, I'm giving you kind of a softball to talk about ADT feeds and the kind of, how do we get out of the I don't want to share anybody's data kind of mode, and where are we in that?
All right, I'll start with a patient story that it literally started a couple of days ago. One of our field teams that work in southeast corner of Virginia was telling a patient story. A really remote rural health clinic. They're 45 minutes from any hospital. Monday morning, the administrator goes in, as she does every morning, and pulls up the app that we provide that lets her know which of her patients have been discharged from the hospital since last she looked. And so found out about a discharge, immediately called the patient, as she routinely does, and found out from that patient, I went home Saturday, and then when I got home, there's a message on my machine, and it was confusing, and I think they were telling me not to take my meds, and I didn't know which one not to take, and there had been anyway, as is not atypical for any of us who work with patients with complex lives, there was a lot of confusion about what the patient. So he had not taken any meds. She said, "You need to come on in." Unfortunately, his blood pressure was sky high, and he had new EKG changes. So ended up right back in the ambulance and back to the hospital. But the part of the story that I want to emphasize is he had just gotten discharged from a Virginia hospital, and that's how she knew about it. 3 weeks earlier, he had been admitted in Mount Airy, right across the state, and transferred to Novant, and discharged home and then bounced back. And we didn't know about those. So she didn't know about those. And nobody let the primary care practice know. And that patient has been in a whirlwind of fragmented and costly care for over a 3-week stretch. And so many states are struggling to bring alive the notion of health information exchange. And in many states, we have to work with multiple data partners to try to get hospital notifications to our practices. North Carolina is not at the head of the pack here. It's been a struggle, and the HIE is making a ton of progress and working really closely with us to try to get ADT notifications to our practices. But I don't think it's widely realized that most healthcare systems, I think all of the major healthcare systems that I've seen here today, with the exception of UNC, thank you, are participating in the North Carolina HIE only to the minimal extent required by the law, which means I will send Medicaid and state health plan patient data. And that is not a whole population solution. That is not a multi-payer solution. That does not help us to actually drive systematic change in how we communicate and deliver care to the population. So I don't know what I can't speak to the barriers, but we have to have the will to this is 2019. This is not technically hard to send discharge notifications. We have to have the will to get this done.
I'll just pile on that one. I can't imagine doing good quality care management without real-time ADT data. I was actually shocked about a couple things. One is that we still don't, maybe you guys now have 100% of the hospitals signed up, but I think there's also a gap with the behavioral health facilities, which is a really important part of what we're trying to do with Medicaid whole person care, even within the standard plan, is to be able to manage patients that are coming out of behavioral health facilities who are also being cared for in primary care. And so we're doing this elegant workaround at WellCare, hoping that we get a request for an authorization from the facility, and then we take that out of our system and move it over to the care manager, so the care manager knows that they're there, and then the care manager can kind of ping the system for when they get discharged, and then the care manager can dive in and do what they do. The other comment I have about ADT is when I was at Duke practicing, we had ADT within the Duke system that was instantaneous within Epic. We had ADT from UNC and other Epic facilities if the physician there was kind enough to ship it our way, or if we were seeing the patient anyway, we could go out and see it, but it wasn't a push notification. But I'll tell you that I called the emergency room a number of times when a patient of mine hit the door of the ER and said, here's what you need to know about that person that's not immediately visible in their medical record. And had it been a once a day, 24-hour thing, I would have missed that opportunity. And so that's the other piece of it. And I know right now we're working on a 24-hour thing, and we've talked with you all about how at some point we can get it to be more real time. But ADT is just really critical. Our care managers needed it. They knew when patients got out of the hospital. We got a notification to them, and they were able to really follow up quickly with folks as they came home. And that's the most vulnerable time for patients. So it is, it's a real challenge. The other thing is there are other solutions out there. They happen to be very expensive. We've, poked around at all of them, and none of them are perfect. And so I think some of those are more multi-payer, but there's a big price tag attached. And it just seems like we should be able to solve this problem. So.
So I'll add something really quickly. The answer, I think, has to be yes. We have to share data, unless we're happy with the outcomes that we're getting, unless we're happy with the healthcare premiums we're paying, the quality that we're getting, and the experience. This is our shot here. We have information. It can be used. I think that there's a couple of things that are tough about it. One is that everybody, I like the way Annette said it before, of your data is my data and my data is my data. Data as an asset is very, very valuable. I don't know if you guys saw that article in The Economist. It was the lead article that said something like, oil is no longer the world's most valuable asset. Data is. So we have to get past this. We own something that's very valuable, but we want to give it away at the same time. The second thing that we have to kind of get past, I think, is there has to be an acceptance that it's not perfect. When I became the CDAO of Blue Cross North Carolina, I had no idea what I was getting into on the data side. I knew the analytics side. But the data part, until you actually get into it, you don't really have a full understanding how messy it is. And what I would just raise of hands, how many of you guys have seen a flat file, source system file, and what it looks like? Good. That's way more than I was expecting, and it's almost nobody. What I would say is that when you see reports in your company, when you see information, it is so massaged, cleansed, worked on. If you see a source system file and you see with the identifiers on it, you see all the holes in the data that you have to derive definitions on so that it can be used, it's difficult. So there has to be an acceptance that it's not perfect, and that when we go out and we start sharing it, it's not going to be perfect. And what I would say is that if you have a plan of owning this asset, keeping it within your company, and never sharing it, it's kind of okay that it's not perfect because you're not harming really anybody else. You get into a data sharing environment, everybody wants it to be perfect, so there has to be this kind of path to getting there.
A couple things to add to that on the ADT. So I think one of the things I was asked to talk about, we debated whether to mention APIs because we don't want to nerd out too much. But let me just mention APIs, and that you can think of an analogy of the world we're living in today. We exchange the data as if we're sending snail mail. You kind of take something, you package it up, you put it in a box, and it disappears, and you're not really sure what happened about it. APIs will enable us to do it more like email. You send it, it gets there in real time. If there is something weird or corrupted, it gives you an error, hopefully an error you can understand, and you find out what happened to it. You've got some provenance there. So we're moving in that direction to try to exchange the data by APIs. Another thing, there's sort of a common joke in data standards of the wonderful thing about data standards is there's so many to choose from. This seems to be the case with the ADT as well. We've got the HIE with the state. We've also got vendors, a few vendors that do a lot of this, and each of them gets some partially overlapping subset, and that's part of the problem. We need to be clever and creative about how to align those. And I'm not sure how, but know that this is a priority on the state side to try to work this out. So stay tuned.
I was just going to say first, it's so exciting to be a neurosurgeon and maybe have a chance for once not to nerd out the panel. But we've said, and a number of people have said, and Mr. Kohler earlier today said a little bit about changing the rules. The system that we operated under created the behaviors that we have about sharing data. And so it would be a continued transition of the healthcare system that would suddenly make it in everybody's interest to share data, because that data would become more valuable if I shared some of mine or a lot of mine and you shared a lot of yours. We can legislate it, right? That's the other way to do it. But I don't think we'll shame folks into it, so we've really got to continue to encourage the movement of the system in a way that looks at patient health, and that will drive us to share data, because that will make us more successful as participants in patients' health.
That's great. I'm going to ask one more question and let anyone to my left answer or not, and then we'll take your questions. I'm not sure how much time we have because I think we're running a little late in the last panel. So if someone would just give me a high sign we'll keep going till dinner if we want to talk about it. 10 minutes. Okay, thanks. So my question is really about, and this is sort of a topic that could be asked, or a question that could be asked on any of the panels, but I'll ask it to this panel because this is the one we're in now. And that is about the time horizon problem in healthcare. Think about if you're insured by Blue Cross, and you're an actuary, Patrick, so you'll know these precise answers to this probably. But you're in that plan for some period of time, and then you switch to a different plan. If you're in Medicaid, just by the rules of the Medicaid program and eligibility classifications, you're just not permanent. You're there for a little while, and then you're gone. And if you're in Medicare, increasingly, it used to be that in Medicare, once you hit 65, you're in Medicare until you die. Well, now you have Medicare Advantage, which is the fastest growing segment of Medicare, and you can switch from plan to plan over time. And so what this concerns me about this is the kind of chronic underinvestment in things that we know could work for a patient's health, but can't accrue the benefit to the payer paying for it long enough. And this seems to me to be a systematic challenge, and if you overlay on top of that kind of the political time horizon that we often operate under, it won't be long before there's a new election, new people coming into office with new priorities and so on. I just wonder, how do we build toward, this is a hard question, so I'm just throwing it out there for anyone. How do you create a information infrastructure and make progress against this very difficult challenge of getting more information to the right people and building toward interoperability when you have all these time horizon challenges of progress, step forward, 2 steps back, et cetera? Anybody want to take that one?
Well, I'll jump into it. And a couple of thoughts. One is my first off-the-cuff thought, well, that's what the quality measures are for, right, in a sense, because, I hope, I don't know any organization I've ever been part of that has said, I'm not going to invest in that because it's good for somebody's health, but they're not going to be a member long enough that it's going to pay off. But the quality measures, honestly, right? There was an interesting article about tobacco that being a smoker actually saves Medicare money because they die before they get to Medicare. I mean, that's a sick statistic, right? I think it's true, but I honestly, every healthcare organization I've ever been in, whether it was a payer or provider, wants to do the right thing for the patients. And the quality measures are really kind of there as an insurance certificate to say, here are the things that we believe are important for health. Now, maybe not Dr. Cohen's health so well, because we haven't yet really figured out how do we measure real health, but the sort of secondary and tertiary ways that we look at health. So that's all well and good. The other thing I will commend Medicare transformation as it's designed is that we're getting 2 years of claim data on the member or the enrollees that are coming into the plans. And we're required by design to hand all that data off to the future payer. So it's acknowledged that the Medicaid enrollee is going to move between plans on, a couple times a year, I think, is permitted, and they may have other reasons to move even more often than that. And that data will go back and forth between us and the future PHP or back to Medicaid fee-for-service. And so the one complexity in that is that I'm going to get data from you, and then I'm going to hand it back to you, and and then it's the same data that I already gave you, and how do I keep track of that, right? So that's creating some nightmares for our data people to try to understand how they keep track of all that. But there is going to be a reasonably continuous stream of at least the claim data and the auth data and the pharmacy data going back and forth in the system, which will help mitigate a little bit of what you're talking about. I know Patrick can comment on this, but Blue Cross unified their IDs a while back so that when patients re-enrolled with Blue Cross with a new employer, they didn't lose the history that they had on that person. So we're getting better at it, but...
Thank you for saying that, Jeannie. Jeannie has actually, back in the day, worked with me on a lot of these problems. What I would say is that if you look at something like, let's say, a care management program, and you say, what's the ROI return? Let's say it's 5 years. And let's say that the turnover rate on your book of business is 18 months. You can really easily come to that conclusion of, is it worth the investment? But I think that's a really short-sighted view. And what Jeannie said is really the rationale for that. With Blue Cross Blue Shield North Carolina, sometimes we'll say, hey, not only do we insure a lot of North Carolinians, but if we don't have you today, there's a pretty good chance we had you at some point in the past. And I think the way you got to look at this is, even if you're investing in that person's health, you lose them, maybe your competitor gets them, you're going to get them back. And what's good for that kind of the population health of the community is good for your company. I think the way I like to think about it is, things that are good for this state are also very good for good companies in this state. And so you have to get past just competitive differentiation and say what's really good overall.
From the provider perspective, one of the great challenges for us in building a value-based system is we not only have to figure out how to do it really well, but we got to figure out what day we're supposed to be good at it, because if we arrive too early, that can be as big a problem as if we arrive too late. And so we like to say that in value-based care, it's the second mouse that gets the cheese, right? The second mouse gets the cheese. So you arrive too soon, that can really be a problem. And so we need to partner with the folks that are guiding this, Secretary Cohen, Blue Cross, and others. There needs to be early successes for the providers that are willing to do this. They don't all have to be financial, but it needs to be. It can't take 5 years for each place to figure it out because there's too much of the role you described. There needs to be an on-ramp for folks who are willing, with a rapid education and a chance to be successful, so that you can build some institutional momentum, so that when these bumps in the road come with changes in systems, you can weather those.
It's great. Oh, go ahead.
Just add one quick. I mean, the good news here is that it's, the payer is not taking care of the patient. The provider is, and so the vision that we are collectively, hopefully, working towards is that we are trying to change the way people interact with people around their health and their health care, and we got to get a lot of little pieces aligned. We got to get the critical mass on with more payers involved on making the right thing the profitable thing. But when they're working in practices and in our healthcare delivery systems around making the right thing the easy thing, those are systematic changes, hopefully, once we get to critical mass. And it's about interacting with patients and their communities in different ways than we have been doing in the past 20 years.
I lied. I'm going to ask one more question, then I'm going to go to audience questions because I think we have a little bit more time than I thought. So the last question it picks up on a theme from Secretary's comments this morning also about the real asset here is the collegiality and sort of working relationships that North Carolina has that a lot of places don't. It makes it hard to externally sort of to transport this to other places that may not have that kind of social fabric that's long-standing. I so appreciated Pam's slides, wherever you are, Pam's slides from the 40s. It's not like we just started thinking about these things recently. There's been a lot of effort and a lot of people involved, shifting from organization to organization, but still working together. My question is for Matt and Patrick, just to operationalize a little bit in the context of this Blue Premier system. Let me summarize what I understand about Blue Premier and tell me if I'm right, but I'd like to get a sense from you about sort of what it means from a partnership standpoint, really, under the hood. So as I understand it, Blue Premier means we're going to sign an agreement together that's 3 or 4 or 5 years, and that we're going to share data together, and we're going to be our teams are going to work together, et cetera. By some number of years in this 5-year contract, say, there will be an agreement to share total cost of care, downside risk, as well as upside sharing. But the idea is that we're working toward that both on identifying the kind of problems that we can solve together to lower cost and improve outcomes, improve our patient experience, but then actually acting on those together. And I just wonder, did I get that, first of all, did I get that more or less right? Is that more or less what Premier is about? Okay. So from a data standpoint and respecting your comments, Patrick, about, you've got to work toward the workflow, how is that going to play out in Blue Premier systems, or how is it working now where you sort of co-create instead of imposing Blue Cross tools on the unsuspecting system and saying, please use them just the way we built them? I gather there's more of a co-development kind of mindset and partnership there.
Maybe I'll start, Matt, you can add. So when I think about how we've worked with providers in the past and how this is different, we would go to the provider and we'd say, hey, what kind of information do you need to manage your patients? And they would say, well, I need this, this particular field of information. And we'd say, well, you have it. It's three columns over in the report that you have. And the reason we ran into those types of problems was because we were developing things without really understanding what the providers wanted and what they could use. And then we didn't train them at all on the information we were sending. That was the second bad thing. And then maybe the third is that we gave the information on a very non-timely basis. So it wasn't really actionable. And so did a fair amount of work to really get very little value out of it. I think what's different about Blue Premier is we're going to our strategic partners and we're asking them, what do you need to do? Like, how are you handling your patients? When a patient comes in, what information is it that you would need? How would you like to access it? And what time do you need to have that? Because I think the ultimate goal is we'd like to get insight into a provider's hands at the point of care delivery. That's what we're working towards. We're not there yet, but we're working towards that so that the provider has the best information available to them to deliver and make decisions and deliver care effectively. So I think that from Blue Cross North Carolina's perspective, working with UNC and others, it's almost like starting from scratch and saying, what do you need? How do you want to access it? What I can't answer, which I hope Matt will comment on, is how do you get it into the provider workflow at that point? Once you have it, what will happen?
So I think it's a great answer. I just add, I think for us the difference that we feel is in the past arrangement, I think your job was to get all of that on a disk or a floppy disk or whatever y'all call it, and that's a more fancy term than I plan to use. And yeah, sorry about that. And hand it to us and say, here you go. And now I think we really are trying to co-develop. This is what we need to better take care of these patients. And there's much more of discussion about what you call customers and we call patients, instead of just about the contract says we have to give you 9 rows of this and it's all there. I think we're done. And so that partnership, I think, gives me more hope that we'll be able to move the cost of care.
Yeah, and one thing to add, because that I appreciate you saying that, we are more in a test and learn environment than we've ever been before. So it's not just let's spend 3 years of development to get you exactly what you wanted to the business specs that you gave us. It's more, let's try this particular thing, see if it works. Did it? No, we'll tweak it and see how it goes.
Can I add one last comment, having been on the other side of Blue Premier when I was at Duke? So, we needed to know who the patients were that Blue Cross thought were in Blue Premier at Duke, right? And the reason we needed to know that is because we were being held accountable for cost and quality, and part of the cost equation is make sure we're getting the coding right and all that. And so the first thing we did was put flags in the EMR. We added them to our quality database. That meant that they showed up in the registries with, an annotation about here's all the things that these people need. We were able to hand that off to care managers for workflow. So there were a lot of things that data, we immediately acted on it when we had it available to understand who the patients were and what they needed. And I know Jan is busy doing all that same stuff at UNC as well.
So that last three, thank you for all of you for addressing that. To me, the next time the New York Times writes about North Carolina, which will hopefully be soon, I hope that this last bit is what is talked about. It's not the technical whiz-bang or the big announcements. It's the ability to roll up our sleeves, earnestly focusing on health, recognizing there are very different interpretations, organizations designed very differently for different outcomes that are willing to go at it in a humble way and an agile way. That's really exciting, and I think that'll be what helps us deal with the time horizon problem and legislative uncertainty and so on. All that said, what questions do you have? Yes.
Thank you. First, I want to thank you for informing me that I'm probably one of the wealthiest people in this room, because I've had practice for 27 years and I have a lot of data that I'm still trying to tap. Okay. But my question is, it is that, and it is in the private or in the independent practice setting, we do have a lot of data. We know what frustrates us in regard to practice, kind of like, the prior auths. So we know that frustrates us. And we also know what causes burnout, a lot of those features. But we also know what makes us feel good. And when we have the opportunity of actually thinking about office-based research and having this data that we can utilize for the care of the patients in our community, what's the potential for that?
That's a huge opportunity. How many people here have heard of the concept of the learning healthcare system or the learning health system? So the idea is, Victor Zhao is raising his hand, I'm glad. So yeah. The idea being that we've always done research to inform clinical care, but now with the adoption of electronic health records, every single time you go to the doctor, that's a piece of data that could be collected. We could be leveraging that and learning from that, as opposed to just leaving it on the table. The tricky part, and academic medical centers are already doing this, mining that data. There's a lot of ethics involved in this, ethics, legal, social things to say, consent, what does informed consent look like? Important things from a smaller, and I don't know if you're in a large practice or a small practice, here's where interoperability is key, because any given practice, if you've got a roster of 1,000 or so patients, that's interesting and that's good, but they're probably pretty heterogeneous and there's only so many conclusions you can draw from that. And so there are initiatives around the country to try to bring together large academic medical centers and the smaller places to say, if we pool our data, what conclusions can we come to? That, of course, brings up the problem of the data sharing. People are generally not comfortable saying, sure, we'll just throw our data all out there and we can pull it together. And so that's created some innovative ways to approach this and say, well, we're not going to all share our data, put it centralized, but we can ask a question. We can say, how many of your patients meet these criteria? And then you can send the question to the data sources, and we can all pull that together and try to learn from that.
Good afternoon. My name is Jacqueline Nickpour, and I'm a nurse and a PhD student at Duke University. Dr. Ewend, you mentioned that on the day that you watched that Super Bowl commercial that you didn't know who won. It was the Philadelphia Eagles, and as a diehard lifelong fan, I will never forget that day. But I will also never forget that day because I was working a day shift and at the hospital where I worked, and literally right before I left and caught my Uber to get home and catch the game before halftime, I had a patient who I was not caring for that day, but I had cared for many times in the past, and I had developed a very strong rapport with. And she came up to me, she was an 18-year-old girl, and she said, Jackie, I just wanted to say goodbye to you. I'm getting discharged tomorrow morning, and I want to thank you for all that you've done for me, but just so you know, I'm not going to be coming back because I'm not getting the care I need here. And this was a girl who had a number of physical issues. I worked on a GI, endocrine, and liver transplant floor. But she also had behavioral issues that were worsening her physical, she was somatizing her trauma and depression as chronic stomach pain. And there wasn't the data or the coordination at the hospital for us to know what she had gone through before she showed up as a patient the very first time. And there certainly wasn't the coordination to get her the care that she needed when she left the hospital. We kind of just said, okay, all of her tests came back clear. We don't see anything physically wrong with her. We know that she has these behavioral issues that she's somatizing, so we're going to diagnose her with factitious disorder and discharge her. And that was all that happened. And so my question for, I guess, anyone that kind of wants to take this is, how do we not only get that data through these exchanges, but how do we use that to actually integrate our patients' medical care needs with behavioral health needs?
So I'm going to tell a slightly different story, but it, I think, touches upon what you're describing. So one of the little data experiments that was going on at Duke when I was there, and I think they're still working on it, was natural language processing, looking at the electronic health record notes to identify what they called ACP-like conversations, so advanced care planning, because in the ICUs, in the hospital where patients were critically ill, trying to figure out where in the health record somebody had said who the responsible family member was, or had they had any conversations with the patient around what the patient would want if they became critically ill or if things didn't go well with their illness, what were their goals of care. And they were actually able to identify a set of kind of key phrases, and then they put that together into a little map directly into the record, so that when the ICU doc was taking care of that patient, they could pull up that map and click on the stuff in the map, and it would take them to that place in the record, and then they could read it in context. And I think that that's an untouched, it's very geeky, I'm sorry, but it's an untouched area right now in healthcare data, or we're just learning how to touch it, which is there's all this really rich information in the clinical record, and the kind of thing you're describing may well have been more contextual than hard data, right? It's not an A1C value or a CPT code or an ICD-10 code, but it's what's the context around the patient that when they show up in the hospital docs might not either have the ability to find or the time to find to kind of fill in the gap.
This is somewhat of a rhetorical question, and I think y'all were about to get there, but I didn't hear it, and so I want to say it. And to me, it's not my insurance company's data. It's not my physician's data. It's not my health system's data. It's the patient's data. And as a patient, I want that data to be in the hands of everyone who's taking care of me, to make sure they can make the absolute best decisions about my health. And I think we've got to think about it above that. And I kind of heard that, but the bottom line, that data shouldn't be proprietary. Excuse me, I'm tongue-tied today. Go Dogs, right? But ultimately, I'm just lost now.
So Greg, you're an informed consumer. We had folks at Duke that wanted to opt out of the ACO data sharing. What that really meant, I mean, we already knew everything about them. All it was doing was disallowing Medicare to send us the claims that we had already pretty much filed on them. So I think there's a lot of suspicion by folks who are less savvy about healthcare. When HIPAA came around, the first thing I did was raise my hand and say, I want everybody to have my health data because I don't want to see a provider who doesn't know my health history. And my father actually wrote a letter and had him put it on the front of his chart, having a daughter who was a physician, saying, anybody who ever wants my health data, please give it to them. Because he had the same concerns around things being disconnected. But you're absolutely right. I mean, ultimately, it's the patient's data. I think when we talk about the value of the data, we are more thinking about aggregated data and what we can do with aggregated data. But the advent of my chart and the ability to put the health record in the hands of patients and let them read their chart notes By the way, we all get better at writing our notes when we know our patients are reading them, right? And that's a good thing. That's a good thing.
And
I just want to rag on my fellow panelists a little bit, but I think when you come from a health system background, you tend to think the world is your health system, and we have to realize that. And someone had kind of a great pyramid slide up earlier. You know, the amount of a person's life spent in the hospital system is teeny tiny, and there is the health determinants for that person are much bigger. More than half of primary care in this state is delivered outside of healthcare systems by independent primary care providers, and it is dangerous. The mentality that everything's an epic is doing harm. We gotta share. We need a shared infrastructure around this.
I want to just quickly put out that FHIR and Apple has done some very interesting things using FHIR to enable patients to control their data and pull it from wherever they're getting their care and then share it with other providers. I'll leave that at that.
I wanted to follow up on Greg's comment. I'm Robin Huffman, and I'm the executive director of the North Carolina Psychiatric Association. So I'm working with over 900 physicians in North Carolina who are struggling with the ones who understand how important it is to communicate with their colleagues about a patient's mental illness, and the ones who just are working with patients who would die rather than have anybody know that information. And so as we look at data breaches, I was going to finish your sentence, Greg, with it's my information. I want all my healthcare providers to share it, but that's the only people you want to have sharing it, and you don't want. So I think we're still working in a world, and I really appreciate Dr. Ewend, the second mouse gets the cheese comment. I think I was the one laughing the loudest. I think psychiatry, they were the one specialty that was not given the funding to be trained in how to do the workflow for electronic health records in their practices. So they're a little bit disadvantaged from that perspective. But we're also looking for a world where there isn't stigma about mental illness, where folks can talk about the medications that they take just the same way they talk about their broken arm or things like that. And so we are working back and forth and trying to increase awareness with the patient population and with our physicians, but it's still real hard, and there still are patients who would not get mental health care if they knew their information was being shared. And so we need all the help that we can get from a psychiatric perspective in support and help and how to do this better.
Any quick comments on that, or amens? Amens. Thumbs up. Okay, I'm giving the high sign here. I see the next panel coming in, so let me make an attempt to summarize very briefly, and you can shout me down if I get it wrong. But we started out by talking about health as the true north, and how helpful it is to mobilize all stakeholders in that goal, particularly motivated by real patients. To earn the hype that North Carolina is getting, we're going to need to continue to build on our posture of humility to meet real information needs of all people, including patients, recognizing there are important, very important safeguards to protect, but a lot of different actors at the community level and in the provider community that need to take care of individual patients and populations. Focus on solving real problems in the short run that can continue to build progress toward these longer sort of infrastructure things, and doing so in an agile way, collaboratively, and recognizing that sometimes that means this failed, let's try a better way, and not giving up. And speaking of which, to quote, go ahead and quote an NC State guy, Jim Valvano, not give up in the face of legislative changes and timelines, in the face of difficulties getting information, and in the face of all kinds of other changes happening. We got to keep at it to earn this hype. So thank you all very much. Please join me in thanking these panelists for great comments.